You will be live. Right, pressing start now.
Hello everybody and welcome to the Ask About Asthma Whole Systems webinar. My name is Viv Marsh and I'm a paediatric asthma nurse, and it's my pleasure to welcome you all to the webinar today. This webinar is offered by the National Children and Young People's Transformation Programme. I just want to touch on some housekeeping briefly. If we can move on to the next slide, please. So a couple of things for everybody just before the webinar starts. We do have a Q&A box which you should be able to see at the top of your screen, and this will be monitored throughout the webinar. We aim to respond to all questions. However, depending on how many there are, we might not be able to answer them all. One thing, if you do see a question that you would like the answer to, then rather than typing the question out again yourself, you will be able to like that question, and my colleagues monitoring the questions will then know that there's a lot of interest in that question and we'll definitely get to answer it. It's important for me to let you all know that this is a recorded event and it will be made available afterwards on the HLP website for anybody who wants to watch it again, or any of your colleagues that would actually like to, who haven't been able to join us today but would like to be able to catch up with the webinar. Okay, can we move on to the next slide, please? This is our agenda for the next hour and a half. We've got a really exciting session. We're going to start in a few moments with my colleague Oliver Anglin, who's a GP and the clinical lead for children and young people in North Central London. And Oliver is also the clinical lead for children and young people in the asthma for NHS England. And he's got a really excellent session for us today. And we're then going to hear from Ian Sinner, who's a respiratory paediatrician in Alderhay. And then we've got an excellent educational session with colleagues Darush, Heather, Errol and Tori. So that's our lineup, that's our agenda. And we will leave plenty of time for question and answers at the end, as well as hopefully some time in between some of the sessions for any questions that you might have. I would really encourage you to put your questions to us. We've got a fantastic panel here today with a wealth of expertise that I'm sure that will be able to answer all of your questions. Can we move on, please? So by way of welcome, my name is Viv Marsh, and it really is my pleasure to chair this webinar today. We've seen the agenda. It's a brilliant agenda and we have a brilliant lineup of speakers. I have to say that whole systems approaches are very close to my heart. I know from many years of experience working as a children's asthma nurse in all settings how important whole systems are, and it's really all about, joined up thinking and joined up working. And I think that if we can, work better in more joined up ways and streamline and be more consistent in the care delivery, we will achieve improved outcomes for children and young people with asthma, which is all about what this transformation programme is all about. So I think without further ado now, I'm going to hand over to my colleague Oliver, who is going to tell us all about the whole systems work he's been doing in North London. Oliver.
I can't tell if I'm live yet. I'm not seeing a live marker on the screen.
You are live.
Yeah, fantastic. Okay, apologies for that technical. I'm kind of trained to look for that big flashing red icon to tell me that I'm ready to go, so apologies. Yeah, my name's Oliver Anglin. I'm a GP in North London, and also have some clinical lead roles in the clinical lead for North Central London, also the clinical lead for children's asthma for NHSE London region. So wanted to talk today about the benefits of integrated working and a real whistle-stop tour of my experience in North Central London about developing a whole system response to dealing with children's asthma. Could I have my next slide, please? And the one after that. Thank you. So I think so speaking to this audience, I feel to some extent I'm probably speaking to people who already understand and recognise that that asthma is a whole person, whole system problem. Certainly, in my experience as a GP, I know that you know, some of the issues around better control of children's asthma are around the kind of clinical side of stuff. It's you know, having GPs and colleagues across the system who are skilled in treating asthma. But I also know that some of the children and young people in whom I struggle the most to manage their condition are having difficulties, not because they can't get access to appointments or access to good care, but there's much wider stuff going on for them, both in their kind of social lives within their families, but also across things that are beyond their control, other socioeconomic factors that are beyond their control. So knowing that, to my mind, it seems impossible to look at children's asthma without thinking about a whole system approach to it. So the case for us, how we went about it in North Central London, and these are, as I said, this is work that has started years ago and continues to this date, and we have a limited time to talk through it. So broadly, our approach, the approach that we've taken in North Central London was to start with the willing. So we identified across our patch those people who had an interest in children's asthma and improving outcomes for children's asthma, and used that as our initial kind of drivers and champions of change. And very quickly we were able to pull together some initial thoughts around creating that case for change. So something like this little infographic that we've used here, we found very helpful as a way of beginning to make the case why we ought to be thinking about whole systems change. Can I have the next slide, please? We also, again, this is just another little example of something which is very simple to pull together. This is based on kind of local data, very simple to pull together, but also very impactful. And the things for us, you know, first of all, this kind of recognized idea that three children in every classroom always strikes home when in terms of bringing up the scale of the issue, but also for us this significant issue around children from more deprived socioeconomic backgrounds, 2.5 times more likely to be admitted with asthma than those from their better off peers. So after creating, so this gave us this kind of sense. We had our core group, our asthma champions, and importantly, you know, this was a group across the system. So if you're looking to create whole system change, you need to engage across the system. And even in our initial cohort of champions, we found people interested and committed to change from all areas: primary care, secondary care, obviously, but also through schools, community services, and absolutely critical to all of this was the children and young people and families, which were very much at the centre of everything that we did right from the outset. The next kind of step that we took, so we began to kind of generate this momentum. We'd begun to create a case for change and begun to have conversations with people around the importance of recognizing this as a significant problem, but also a whole system problem. Our next step was to look around for the tools that were available to us, and we were very fortunate in London that the fantastic work from the Healthy London Partnership had created a set of whole system asthma standards for London. And this very detailed, very involved whole system piece of work created something by which we could benchmark ourselves against. So taking this as a kind of gold standard, we were able to look at it, benchmark ourselves against it, and then we went through a peer review process. So this was through all of our acute trusts, working with the 5 CCGs as it was at the time, across the whole system, primary care, schools, community services, all in a process of benchmarking. And the value of this, first of all, was that we got a sense of where we were at. So it gave us a really good indication of what we were doing well and where we were we could do better. But also, by going through this process, which was involved and was whole system, we're beginning to draw more people into that conversation, and expanding that conversation was absolutely, again, critical to success. So if you're looking at creating whole system solutions, you need that whole system engagement from the outset. Can I have the next slide, please? So what we really wanted to do, the real, the kind of place we wanted to get to at the beginning of this work was to create a whole system response to this really significant issue for children and young people. This is where we wanted to get to. And I think what I would say is that it's possible for bright people with the knowledge of asthma to sit down and write a plan for their area. So I think it's very possible for that to be done. However, if you want something to have buy-in from the outset and to have that kind of whole system engagement, then it's absolutely critical that you draw people in from the beginning. So it's not just about producing a plan, it's how you go about producing that plan. That forms that plays a key part in the overall success of where you want to get to. This is why the kind of working with the willing in the beginning, socializing the case for change, going through this kind of whole system peer review process was absolutely was key to the next stage for us, which was then, now we had people's interest, awareness and understanding, we wanted to create a whole system response, a whole system strategy and a whole system plan. And we did this through a logic model process. So we together as a system decided, and as I said, this is as a system, but also always with children and young people and their families at the centre, and being part of this process, we looked at those things which we thought would be the most important outcomes. And this this is basically just to give you an idea. This is where we had got to. This is how we framed with this group, how we framed those outcomes that we thought were most important to us. And again, using the logic model, can I have the next slide, please? So building on this, we were able to understand what the interventions were that would be helpful and beneficial towards delivering these outcomes. And I think for us, again, it's the outcomes that we were achieving. We're not talking about, we were talking about improving lives rather than, picking a reduction in asthma admissions as one of our kind of targets. Obviously, that's something that we hope to see. But that wasn't our aim of doing this. What we're trying to do is improve the lives for children, young people and families who have asthma. And so we were able to then build in the kind of key elements, key pieces of work that we would then need to be able to deliver on, to create and deliver on, in order to attain and achieve these really important outcomes. Next slide, please. So more of the same on the next slide, giving you a little bit more detail about some of the of how the outcomes we'd identified related to some of the actions and activities that we would need to put in. The consequence of this work is that we now have a strategic plan, whole system plan in place for children's asthma in North Central London. We have a paediatric asthma network, which is well established, again, which has representation from across our system. We have a set of priorities that we are working towards across North Central London, and we're able to identify those things which we should do once for North Central London, and those things, those elements which need to be delivered more at a local level through local partnership, recognizing that local resource and local need is going to be different from each area. And with our paediatric asthma network, we're able to share learning. We're able to support and give advice, and importantly, we're able to hold ourselves to account at that level. So next slide, please. So in conclusion to this incredibly whistle-stop journey through North Central London, we have the kind of key issues here for me are absolutely that we need to work together to understand problems, and we need to work together to create the solutions. The way in which you do the work to create your whole system response is a key outcome in itself. If you do the work in a way that is inclusive and seeks for wide engagement, then the results that you get at the end of it will be more appropriate, will be more suitable, and also the aims in achieving those deliverables will be better and easier because of that kind of buy-in that you've had from the outset. You're not enforcing change on people. You are supporting them in their bids to embrace it. So with that, I'm going to stop talking. I think there's a couple of minutes available now for any questions. Viv, if there's any questions, I'd be happy to answer, or we could move on as you direct.
That's absolutely brilliant, Oliver. Thank you so much. As you say, very much a whistle-stop tour of the fantastic work that's been going on now across London for many years, and I know it's been such an awful lot of hard work. I have a couple of questions. So one question is, how did you encourage involvement from primary care? We know that one area has 27 PCNs. It's a large number to engage.
Yeah, it's a good question. I think it's always there is always a challenge around engaging with all of primary care. The way in which we did it was similar to everything else. So first of all, identifying the case for change. So recognizing that this is a significant problem and the impacts that it has on primary care. It was a case of working with the willing, so finding areas that were willing to engage in the first place and use those as areas where we could begin to help and deliver the change, and then use those as examples of the benefits of doing so. It's also important to recognise the levers. So it's understanding what levers you have available to you, and I think certainly looking and understanding what those might be, either through contracting, etc. I mean, certainly for me, one of the key approaches I took was to point out that there's an awful lot of money that's made available to primary care for dealing with long-term conditions in adults, and it is inappropriate that that same rationale is not applied to children. So there's lots of different kind of mechanisms and angles, but also it's the kind of wider thing. It's about you know, education, improving the quality, looking at what levers are available to improve skill in primary care. It's creating templates to improve quality of asthma reviews. It's about identifying where the levers are to bring in extended asthma reviews instead of a 5-minute cough review. So all of these things were critical for us.
Yeah, thank you for that. And just one more question. Did you engage with schools as a part of your whole systems approach?
Yeah, absolutely. This is an area where sorting out adults is very much different from sorting out children, and again, something that we have to continually make the case for to adult colleagues across the system. So schools were integral in this. So working with schools, working with school nursing team, understanding the challenges and barriers they face, understanding the kind of issues around capacity, and I think we certainly, in my experience, certainly found that schools were very open to being involved with this, but what the issue was they weren't either sure what to do or also around kind of capacity. So again, as a system, you're trying to understand, you know, how do we support schools to do stuff that they want to do but may not be able to do. So yeah, schools were, you know, a really big important part, and we are rolling out we have asthma friendly schools in some of the boroughs already in North Central London, and are moving towards rolling that out across all of North Central London over the next couple of years.
Oh, thank you, Oliver. I think that's absolutely right, and certainly that's my experience from my years in school nursing, and also, you know, leading school asthma policies. And we introduced asthma friendly schools back in Dudley in 2003. So for anybody that's on the call today that, you know, isn't already familiar with that initiative, I'm really looking forward to hearing more about that later in this session. Thank you, Oliver. Very much appreciated. I'm sure there'll be more questions for you later when we've got time for Q&A at the end. But we're going to move on now to, I'd like to welcome Ian Sinner, who is a respiratory paediatrician in Alder Hey Children's Hospital in Liverpool. And Ian is also one of the programme leads on the Children and Young People's Asthma Transformation Programme. And Ian is going to talk to us about what the National Bundle of Care for Children and Young People with Asthma means for him as a clinician. And just before you start, Ian, I'm really pleased to be able to make the announcement that the National Bundle of Care has been approved and signed off, and is actually going to be published tomorrow by NHS England. So that's absolutely fantastic news, and it's also a really great start to your session. And I'm going to hand over to you now.
Thank you very much for your kind introduction. That is lovely news. And as you were making that news, I was looking for that clapping emoji button, but I can never seem to find it on Teams. But if I could find it, that's what I would press, because it is great news, and I think it's really exciting. So yeah, good afternoon, everyone. I'm a respiratory paediatrician, as Viv has mentioned. I work in Liverpool in Alder Hey. Got a fantastic team and a fantastic network around, and it's been nice to watch this process develop. I was programme leading up in terms of the clinical lead on the diagnosing asthma theme, and I have to say before I talk about this that there was a huge amount of work from a lot of people at NHS England and also from around the country to pull this together, and as a paediatrician I'm very grateful for that, because I can start to see the benefits that this will have, and I hope you see them too. I haven't got any slides, if that's okay. I was just going to talk through what the bundle might mean and mean to me from a clinical perspective, rather than necessarily from the bit that I was working on. And I took this question quite seriously, because I'm not one for throwing my name behind stuff if I don't think it's any good, and that winds a lot of people up. And I'm not one for holding back from when I think that things are going to fail. And I've seen a lot of things fail over the years, particularly with regards asthma. All of that considered, honestly, I think this is one of the most exciting moments that we're at with childhood asthma. You can certainly feel that there's a shift in how we're going to get things better. And as Oliver so eloquently pointed out, there's an absolute need to get things better. So when I was thinking through this question, I thought about 2 or 3 sub-questions that I'd just like to talk through about justifying that statement, really, that this is an exciting time. So the first thing really is, well, you know, what has been holding us back and how does this bundle help us move forward? And this is a conversation that many of us, and I'm sure many on the call, have been having for, you know, certainly since I became a doctor in 2002. This was something that we were discussing even then. And I think it comes down to 4 things. The first is, there are wider determinants of child health. Again, as Oliver says, children who are from the most deprived backgrounds are more likely to have asthma attacks. And we know that those are the children who asthma is going to hold back more. We really need to start to address the wider determinants of health. And I think this bundle really does start to do that, particularly when thinking about air quality, indoor and outdoor air quality. And I think that's, for me, number 1 barrier in why we're not getting better, is that we have an unjust setup in this country where the most deprived people are hit the hardest by adversity, and we see that every day in all kinds of guises. The second thing which holds us back is the quality of care that we give. You know, it's now 2021. I think we've got something like 3 billion asthma guidelines in the UK. Every day someone's producing an asthma guideline, but how do you actually make that translate into something meaningful in clinical practice? And I think this bundle is all about that. And that was good for me to see that, because I'm often dubious about new guidelines that are written in slightly different ways. We have some great guidelines already. You know, the NICE guidelines, great. BTS guidelines, great. You know, we've got GINA, we've got all kinds of guidelines from around the place, but how do you translate that into practice? And that's exciting to me. I think the third thing that this whole process promotes is leadership across the system. And that, again, has been something that has been lacking, not because there aren't leaders in primary care and secondary care and tertiary, not because there isn't a willingness for those leaders to take things forward, but because children and young people and asthma have traditionally been Cinderella services to other services. So it's great that this is about identifying ways of helping people develop systems such that, how do you make a national prioritization process happen in individual localities and across networks? That's what this is very much about, and I think that's great. And finally, the thing that makes me really excited about it is that, again, everyone on this call will know that for years children have fallen between the cracks. They've fallen between primary care and secondary care. They've fallen between acute services and chronic services. They've fallen sometimes between children's services and adult services. And hugely importantly, they've been falling between health and non-health. We've been saying for a long time that the people that really know which children have got asthma are PE teachers and dinner ladies. And it's great that we've got some school representation on this call from that perspective. So those, I think, are the things that have been holding us back that the bundle starts to address. I thought to myself, what am I most excited about in the bundle? And actually, the thing that really that I'm excited about is the cross-cutting themes at the bottom here. So the idea of having a really good approach to asthma competencies and a training and education program that I've seen develop, led by a great group within the team. I think Jen and Oliver and their team will be putting together something really important for that. And the second thing is the data side of it. We've been slow in health services to realise the benefits of data and how important data are. And I think this is the first time you know, certainly for the last couple of years, we've had the NACAP, National Asthma Audit process, and that's shown us the importance of data. And I think this process also shows us how important data will be. The third question I thought of was, what impact am I going to see that makes me excited? And again, like with everybody on the call, the thing I just want to see is for our kids to get better. It's heartbreaking doing asthma clinics when you feel like your hands are tied, when you feel like all you're doing is if you see these children every 3 months and, you know, 15 minutes at a time, what happens for the other 364 days and 23 hours when you're not with them? And the idea that we have a systems approach to try and address that, I think is hugely important. And that's been one of the things that's different to when we've tried to address this before. And the fact that it's now a national priority to do that, I think is really important. In terms of the methodology of the process and why I've got confidence in what's been happening so far, is that having seen the methodology progress, again, you know, I'm part of various groups, some of them you just can't see how, and you know, we're all the same, we're all with it, we all do things in our jobs where you see some things that you think, where's that going? There's always been a clear direction here, and again, you know, that is credit really to the NHS CYP transformation team and the leadership behind it. I think the things within the methodology that I would like to stress that I think were really positive were that I think it's an evidence-based approach. There was a lot of work looking at the evidence behind things that we were saying. There was really good representation, thorough, comprehensive representation, both geographically and in terms of a multidisciplinary, multi-specialty approach, and across the systems as well. And that was really nice. You know, this wasn't just a group of tertiary regional respiratory paediatricians doing severe asthma clinics telling practice nurses what to do. This was an equally shared process, and I think that reflects in the recommendations that have come out. And within that group of people, obviously, one of the key groups was some really good, bright, eloquent children and young people who brought their lived experience to the table. And the other thing that I really liked about this whole process was that none of it was about reinventing the wheel. If someone's already got something ready to go, you know, why would we muck about for another 10 years trying to sort that out? If we've got data that suggests that something is effective, safe, reasonably cost effective, let's just roll with it. And it was really nice when we, you know, certainly for those of you on the call who are within the NHS, you know, it was really nice and refreshing to see a process where we didn't need to spend 4 years writing a business case for this. That just happened behind the scenes, and this was about making it happen in a very pragmatic way. You know, I can't see, there will be barriers here, obviously, but I can't see anything in what we've put together that is going to fall apart at the first hurdle because it's not achievable. All of this is achievable if we want to achieve it, and I think there is a real willingness behind it. And I think, to just finish off, what needs to happen next from my perspective as a clinician is that there needs to be support for teams locally and across systems to try and pull together some really excellent local and regional work that's been happening to try and consolidate that. You know, what's been happening in Cornwall will not be the same as what's been happening in Newcastle, and that won't be the same as what's happening in London. You know, we really need to try and tie things together in a really seamless way, and that will be the next challenge for us. But yeah, I think that's all very doable as well. You know, if there's willing behind it, it'll happen. And so to sum up on that question, what does this mean to me as a clinician? It all comes back to better outcomes for children. We have we have poor outcomes compared to other high income countries. Our outcomes aren't getting better despite lots of work in lots of areas around asthma. We need something to pull it together. And I think that's what this bundle means to me. And I'll finish there. I think, don't think I went over 15 minutes, but I apologize if I did. Thank you, Viv.
Thank you so much, Ian. And it's great to hear from you and your experience of being such an integral part in developing the bundle, and also, as always, hearing your passion about inequalities in children's healthcare coming through. We have a couple of questions. Just to begin with, do you think translating guidelines is top down and has contributed to the very small improvement in outcomes? If it were grassroots up, we might add to those efforts. So schools, scouts, youth groups, Duke of Edinburgh Young Citizens. Any thoughts on that, about guidelines being top down?
So my thought on everything, whether it's this, music, football, government, school, health, everything should be grassroots upwards. And what we really want is a system where people are supported to do that. And I feel that with this NHS England team in the CYP group, that there is a willingness to do that. I think anything top down is always likely to fail, for various reasons. I'm very much a believer that those lists that list of people that whoever asked that really excellent question put together is exactly the groups of people that we haven't necessarily engaged with over the years. We may be having small pockets here and there, but to bring them front and center alongside the likes of some really big names in paediatric asthma, to bring people together in an equal partnership is the way, is exactly the way to do it. And again, it's one of the things that excites me about this program, that it isn't just being fed down from managers and bosses. The directive is fed down from managers and bosses, but also there's some resource that goes alongside this, which demonstrates that there is a willingness from the top to support people, doing this on the shop floor or the grassroots, or however you want to put it. And I think that's a really important factor here as well. And again, I'm not one for giving credit where it's not due, but I think this NHS England team did well to pull that funding together in a timely way. I think it will matter a lot to help people who are busy on the front line.
Yeah, no, I couldn't agree with you more, actually. And I suppose also in answer to that question, it's just worth pointing out that the transformation team are working with Public Health England, the local government associations, and really trying to draw together all the groups. And also, you mentioned the Oliver and Jen's work stream that I've also been involved in around, capabilities for people working with children with asthma, and actually those groups that Robin mentioned in his question, like scouts and teachers, etc., they're all included in that capability and training framework, which I think is critically important and has been needed for a very long time.
Yeah, no, I think it's great. Again, if I could find that clapping emoji for Jen and Oliver, I would put that up just now. But yeah, you're right. And again, when we think through educational programs that we've had, they've typically been targeted, not wrongly, they've been targeted towards healthcare professionals. But those resources are there now. They're there. They've been well established for a long time, and in and of themselves, they don't make the difference. It's the system approach here that's really important. And when we've thought in the past about models of care for asthma and where they've been falling apart and why integrated approaches are important, one of the key things that we've said is that when children have asthma attacks, or when children die from asthma attacks, there are lots of elements of the system where something could have happened to have made a change. And within that, you need people to have spotted that there was a problem, to care about the fact that that child's having a problem, and to know what to do about it. And again, that's exactly where integrating education into the child's wider life and tapping into the rhythms of their life is more 2021 than us just sort of telling them what to do.
Yeah, absolutely. And there is a sense of in the past that asthma in children and young people has almost been trivialized, really. So it's all about raising that awareness and joining up across the whole system. Ian, just finally and very briefly, could you just talk to us a little bit more about how you think data will help improve children's asthma care?
Oh, yeah, okay, excellent, excellent question again. For the last, certainly for the last few years, data has been something that I've been really interested in. I think there are probably two elements to it. Probably three elements to it. One is that I think we absolutely need data to drive efforts to reduce inequality. As you mentioned, if I do a little bit of stuff here and there about inequalities, and one of the things that holds us back is when we haven't got real-time, linked, up-to-date data that can help us formulate the argument and understand the mechanisms behind inequalities and poor outcomes. The second thing is that alongside addressing inequalities, we need to make sure that we are providing excellent care. If we were to turn up and fight for better benefits, better housing, better smoking, we also need to show that we are doing the best thing that we can be doing in clinical practice. Data, and we've seen this certainly from the NACAP programme, the National Asthma Audit Programme, is that having those data to enable people to benchmark, to enable people to see where they could be improving, to see where they're going well as well. It's very rare that we pass good news messages on to people. So data, I think, for describing our own clinical practice is really important, and for monitoring that practice is a key, absolutely crucial component of quality improvement, which is what this bundle is about. It's about quality improvement. And the third thing I think the data will be crucial for is that, again, from NACAP, we've seen that some resources locally and nationally are underfunded, and having data to put together the business cases that we need for better funded services for children and young people, and in this case for children and young people with asthma, will be another really crucial thing that we need to use those data for.
Yeah, absolutely. Ian, that's absolutely fantastic. Thank you so much. And again, I'm sure we'll be coming back to you with more questions later in the Q&A session. Thank you. Okay, so in moving on now, we've got a fantastic session with 4 absolutely brilliant speakers that I'm really looking forward to hearing about, and they're going to share their insights and their expertise from their own various clinical perspectives on key points on treating and managing children and young people with asthma. So without further ado, I think Darush, you're up first. I'm going to hand over to Darush.
Thank you, Viv. And if we can go to the next slide, please. Perfect. So I'm Darush, and I'm a pharmacist based over in North Central London. I live in Northwest London, and I do community pharmacy locums in a community pharmacy, and I'm also an independent prescriber. So I sometimes work in GP practice settings. But I'm also a respiratory lead pharmacist for the Barnet Borough of North Central London, CCG. So love to get hands-on and run group consultations with children and young people, and I'm also part of NHS Right Breathe. We can go on to the next slide, please. I know I have only a few moments. I could speak forever for about pharmacy roles, but so I'm going to just give you a real snapshot here, whistle stop tour. So ultimately, the patient at the centre, of course, what matters to the person in the middle. We want people to live better with asthma and know what good asthma looks like. And I think as part of the whole systems approach, we really do need to think about streamlined care and delivery. Now, the role of the pharmacist and the pharmacy teams as well is changing. You'd think that pharmacists would in the past be just based in community pharmacies and also hospital pharmacies, but now there's a large, as a lot of you will be aware, a lot of pharmacists working within GP practice settings. And the good thing is, I think with a lot of the schemes that are coming out and services that are coming out that are actually remunerated for GP practices, for pharmacies and discharge medicine services within hospital pharmacy, we're finding actually that the quality interventions can really improve, and that will really help multidisciplinary team working. So I do have a few slides and I will go through quite a few of these things, but just if we start to the bottom right, community pharmacy, just to highlight all pharmacies are now healthy living pharmacies, and you're never more than 20 minutes away from a pharmacy. And I think pharmacy first is a big thing that's being pushed. So there's CPCS, stands for the Community Pharmacy Consultation Service. So GP practices and NHS 111 for patients that will feel that they could get, rather go to the GP, the community pharmacy first, then those patients will be referred on, and that will obviously apply to children and young people as well. The other thing which I don't cover in the slides, but I'll touch on, is is primary care structured medication reviews. These are normally very holistic reviews and looks at reducing overprescribing of medicines and waste, but they also look at avoiding admissions to hospital through unnecessary medicine related harm and various other things. But health inequalities is really big, and it's really big around holistic reviews as well. Now, I think with children and young people with asthma, it really wouldn't fit within a structured medication review, but unless there's some health inequalities and some challenges related there, and I think there's an opportunity where that could be tapped into. I will touch on the other services in my next slide. Next slide, please. Okay, so the new medicine service. This is a service where GP practices via the structured medication reviews, they could refer patients on to have a new medicine service, or if a community pharmacy recognises a patient's got a new, for example, inhaler device, a new medicine treatment with new medicine in it, then that child and young person could have a new medicine service with the Guardian. There were some recent changes because in the past, people under the age of 16 weren't allowed to have a new medicine service. And this is really talking through the new medication and understanding how to use the device that medication's in, for example. But because after a near-fatal asthma attack in a 5-year-old, these rules changed, and now we can actually refer patients on to have that new medicine service. Next slide, please. Something called that community pharmacies have just recently, very, very hot off the press. There's something called a pharmacy quality scheme. So what we need to think about is community pharmacies will ensure people with asthma have a personalised asthma action plan in place, and they were going to promote spacer device use in children that are prescribed metered dose inhalers. So there's an incentive for the community pharmacies to ask the questions, and I think it's important all of us are aware of this service. Anyone during the pandemic, for example, that didn't have their inhaler technique checked as part of a new medicine service, there is a catch-up NMS between 1st of April 2020 and 31st of August 2021, where community pharmacies can get involved with that inhaler technique coaching. Those community pharmacies to embark on this programme would have had to have completed the Centre for Pharmacy Postgraduate Education Training, which is worked in partnership with the UK Inhaler Group. And there's a big push around encouraging patients to recycle their inhalers as well to the community pharmacy, which is really big, good. Next slide, please. And just to be aware that a lot of the community pharmacists and pharmacists within practices and hospital pharmacies will be made aware, of course, of digital and promoting and reinforcing inhaler technique coaching with various apps and websites and videos for people to understand. Next slide, please. And so one of the things, again, hot off the press, literally just come out recently, GP practices, a lot of the GP practice pharmacists have been approaching me, and also other healthcare clinicians, around some of the incentives around promoting quality indicators. And one of the things that's obviously is quality is if asthma is a disease of inflammation, then we need to promote as much as possible regular use of inhaled corticosteroids. So there is a big push around as part of this directed enhanced service to try and promote as much as possible regular use of inhaled corticosteroids. So primary care networks have been contacting me about this. And the other thing, of course, is keeping patients safe, and anybody on 6+ SABA or short-acting beta-2 agonists or the blue inhaler per year we want to reduce this down to less, it should be really 0%, but we want to get that down to 10%, below 10% if possible. Next slide, please. So one of the great ways of linking in between hospital, community pharmacy and GP practice is that people, for example, that maybe obviously had an acute asthma exacerbation, ended up in hospital, they may have been given changes to their treatments, and there may be some confusion around what is it that I need to do, why is it important to take that inhaler, for example, and it's hard to retain all of that information. So the good thing is, for example, the hospital pharmacy can communicate with the community pharmacy to do something called a discharge medicine service, just to prevent people being readmitted back to hospital. So really thinking about how we can reduce harm and reduce exacerbations again, and improve adherence to preventative treatment. So there's a lot of work around this and it's a remunerated service as well, which is great. Next slide, please. And as I said, there are 3 stages to this, and also the new medicine service has various stages. The good thing about these services, there's follow-up. So not only do the patients actually seen initially to have that initial consultation with the community pharmacy, there will also be a follow-up and of course time for the person to ask questions and correct any misinformation that may have been taken place as well. So this is just to highlight that it's not just a one-off consultation. There's multiple sessions to achieve that, which I think is great news. Next slide, please. That's me done on that. I don't know if I've got overrun there, Viv, but as I said, I could talk forever on this subject.
Always a pleasure to hear from you, Darush, and it's great to get the pharmacy and particularly the community pharmacy perspective. I think it's so important, and I'm quite sure we'll be coming back to questions for you in the question and answer session at the end. So thank you. So we're going to move on now to Heather Robertson, and Heather is a children and young persons nurse and also a school nurse. And Heather's going to tell us a little bit more about the whole school asthma approach and asthma friendly schools, which I'm really looking forward to hearing about. So Heather, over to you.
Hi, afternoon everyone. Thank you, Viv. So my name's Heather Robertson, as Viv said, and I work in the London Borough of Newham in the Children's Health 0 to 19 service, more specifically leading the school health service and leading on this project. So those of you who know the role of the school nurse, we are involved in just about everything to do with children and young people's health in schools. But, asthma, that it is, our most prevalent condition, and it is something that we are really heavily involved in Newham and really proud of this approach. So we have adopted the asthma friendly schools criteria, and we have added that into our whole school asthma approach, which is, as the name suggests, about making sure that everyone in that school environment is aware what asthma is, how to identify it, how to support, how to in emergencies, etc. So really it's about just creating that awareness, and this is kind of how we went on to do that. If I could have the next slide, please. Thank you. So we started this back in January 2020, and we had an initial meeting between our service, so in LBN, and with the asthma clinic in East London Foundation Trust, so with Emily. I'm sure lots of you know Emily. And we drew up some plans, we agreed what we were going to do, how we were going to implement this. And at this point, although I haven't put it on my slide, interestingly, we did audit all of our schools. So every year we profile our schools, we do a school health needs profile. And in that particular year, we added in some questions around asthma. So we added in the asthma friendly criteria to audit our schools against those and see where we are. At that point, we had around 25% of our schools had emergency AAIs, and around 38% of them had the spare inhalers. Lots of them, I would say maybe 10% had an asthma policy, so lots of them didn't. Lots of them were using the DFE document as their policy for health needs. And so obviously we had identified a gap there. Of course, then pandemic hit. Everything went slightly, didn't quite go to plan at that point. But we decided that we were still going to push through with this, and we reconvened in April once things not had calmed down, but we kind of, knew what we were up against at that point. And we thought, actually, there are lots of things about this pandemic that mean that we need to continue with this work. And also there were lots of things that kind of lent itself to us. So this new virtual world, it sort of lent itself to this project in terms of the wide coverage that we had to cover in terms of engaging all of our 106 schools. So during April to June, we designed a school-based asthma action plan. Now, we know that children with complex asthma who are under the care of asthma clinics and under the care of the hospitals, etc., they need their individual personalised asthma action plans. But there are lots of children who are GP managed that haven't always got a plan, and what do we do for those children? So we designed this universal asthma action plan between ourselves and ELF. Lots of people looked at it, lots of people make suggestions, and lots of hoops to jump through. And we piloted it with one primary and one secondary school. We had some schools that were really on board with this idea, really wanted to get involved, really wanted to improve things. And so we started to pilot it. In July, we created some films, so 5 short films that were led by children from Newham who have asthma. And the idea was that they were able to teach other children, other young people, other families and their teachers, which they found really exciting, about how to look after them and others with asthma. Those films were really great experience, and really kind of made use of emergency COVID budget funds, because we knew that we couldn't go out and do the teaching in quite the same way, and so we wanted to think of a different way that we can do that, and that was one of the the ways that we did that. ELF, so Emily's team, trained 40 of us in children's health to become asthma champions, so really great training. It was a hybrid of virtual and face-to-face, because we still decided that was important to have that face-to-face element to be able to check, our spacer technique, our inhaler technique, etc. And also we met with Alison in Hillingdon to share good practice. We know that they had a really great asthma-friendly schools approach in Hillingdon, and we met with them to see how they were getting on and what advice they could offer us, and that was invaluable. And we of course took this through our governance boards, both at LBN and at ELF, and that got passed through in August, thankfully just in time to launch for the new academic year. We launched it at the Head Teachers Forum on the 17th of September 2020. We had almost every single head teacher and deputy head teacher in LBN on that call. Again, virtual. It was great, kind of supported people to make sure they could be there even in that busy period of time. So in year 1 of our whole school asthma approach, we have trained over 3,000 school staff in asthma awareness. So that's those key messages on, like I say, how to identify signs and symptoms and what to do in emergencies, etc. We also talk a lot about some of the stats that were given in earlier slides, so 3 per class as a benchmark, because some schools were sort of telling me, oh, we have 15 children with asthma, and I thought, oh, you don't. So we talk about things like that to raise those kind of awareness, and about, the fact that we do have 12 children every year in London die due to asthma. We talk a lot about indoor and outdoor pollution, and also air quality, and also, the fact that we are in East London. We do have a poor social economic group, so we talk about the implications of that. Talk a lot about pollution. That really heavily features in our training, and so this journey has led us to have 90 schools signed up to the whole school asthma approach. Depending on how you categorise our schools, and there's different ways because of different provisions, etc. We've got 106, so 90 of those schools are signed up. And I've met with them. I say 76, we've moved on from that now, but in year 1 we met with 76 schools to discuss this approach and discuss how we were going to make their schools asthma friendly. We then provide a more in-depth training for those, we call them the first responders, so those who, medical officers, first aiders, SENCOs, etc. We train them in a more in-depth way. So as opposed to the shorter asthma awareness training, we provide a half-day management of asthma and allergy training. And so 400 of school staff have been exposed to that last academic year. And at the end of the last year, we had 20 schools signed off as asthma friendly and have our posters displayed. If I could the next slide, please. So how did we do that? How did we do that in year 1? And despite everything else that was going on. So as I said, we launched it aligned with the Head Teacher Forum just to make sure we had a captured audience. That generated a lot of interest. The chat box was going mad as I was talking about it, of all these different questions, taking email addresses, etc., etc. Started really a good start to it. And so we do these individual meetings. They're 20 minutes. Again, this is where Zoom and MS Teams has come in brilliantly, because we haven't got to travel to the schools. We can just have these quick 20 minutes. But what these meetings do is put a face to the name. It stops it just being email conversations going back and forth. They know me. And then apart from just all the asthma work, it's been brilliant for relationship building with schools anyway. So now anything to do with school health, they now come to me because they know my face, which has been brilliant. And likewise for me, I've now found lots of allies in schools who I go and have a little chat with about various things because we've built that relationship in those meetings. So I really think they've been invaluable, like I say, for the project, but also our working together in general. We do lots of emails because we all do, we have to. We do send monthly emails to all schools. So we've got a mailing list, we send them out to all the schools. I have it all set up, automated, and it sends out all of our training information, all the information about whole school asthma, any other new things that have come out about asthma. And we like to not identify outliers, I don't call anyone out, but certainly if I've got 76% of schools signed up, I'm going to tell them, because if you're in that percentage that isn't signed up, it's going to kind of make you want to get on board. So we do that a lot. I like to make things easy in inverted commas for them. They're incredibly busy. Every school is different. In Newham, we have absolutely humongous schools, 5-6 form intakes in primary schools, really massive schools. They're really incredibly busy. So we want to make it easy for them. So how can I do that? Well, you know, we want them to have an asthma policy. Let's write one for them. So we've adapted and co-written the policy that they can adapt and localise. And the minute you tell them about that in the individual startup meetings, you can see them relax slightly, because you mentioned they've got to write a policy. They think, oh my God, where do I start? You then tell them you have a template, they relax, and that's what they want. We also keep our asthma awareness sessions nice and short. That was key to engagement, or allowing us to come in and do them. It does mean I have to talk really fast, probably even faster than I'm talking right now, but it's so that I can fit it into their CPD time, their twilight sessions. I go in before school, I go in after school, lunchtime, inset days, whatever they want. The minute I hang up from this call, I'm on my way into one of our schools to do another 100 or so this afternoon training. So yes, it's really key is fitting it in. They take it over the time because they have all these wonderful questions and ideas and get really intrigued. And then I have a queue of people standing there to ask me about their own child and their own asthma and their own experiences they want to tell me about. So that's been another really brilliant thing, is obviously, apart from making the difference for the children and young people in our actual schools, the ripple effect really, I mean, I want to try and work out how I can measure it, but this ripple effect of course, you know, there will be people in the audience who have asthma, there will be people in the audience who have children who have asthma, and so on, you know, so the reach is much wider than I think we ever intended. And we talked in earlier presentations about finding their levers. So what is it that they want? Some schools really want the policy, some schools really want the training, some schools really want the poster. So it's finding their levers. What is it about their school that that will, you know, kind of get them on board? And you know, when you get to know more about the schools, you get to know what's going on at schools, you'll find those levers and use those to your advantage. I'll hold back the poster until they've jumped through all the other hoops, for example. Finding their change agents, that's really, really important. Find the person who's passionate about it. Find the asthmatic members of staff. They will push these things through. You know, one school, I was talking to a member of staff for a long time. We were really getting nowhere. A particular lady came back from maternity leave and they were asthma friendly within about 4 weeks. She was so passionate about it. So she's my go-to person. I also do a lot of shared learning across schools. So lots of our schools are in kind of federations. And so if I have a school that's a bit hesitant about it, I'll find out what, you know, and then I'll go, oh, you know, Mrs. So-and-so in that school, go and speak to her. She really enjoyed it, and you link them up that way. I keep it on the agenda, kind of comes into making every contact count. So, you know, I might be in the school to talk about, I don't know, SEND, but I'll still mention a little bit of asthma because why not? So it's just keeping it on the agenda, keeping it at every single meeting that I meet with them, keeping it on the head teacher's bulletin. So there's a weekly head teacher's bulletin in Newham. I keep it on that. So every week I go to the education team and say, please put a bit about this in your bulletin. And And also I have an asthma lead mailing list. So once they're signed off as asthma friendly, I put them onto my asthma lead mailing list, and any information I get from yourselves, if it's appropriate, that goes to schools so that they get that information. And likewise, we have an asthma champion mailing list for our asthma champions in our workforce to then disseminate that information across their teams. And so that comes into that monthly briefing for school health and health visitors. We are looking at, I'm looking at sustainability and succession planning. At the moment, you can sort of tell I sort of lead this, but like I say, we're not an asthma service, we're a school health service. So really, making sure that my team are trained and that others are able to do it should I not be here tomorrow, for example. Anyone who knows me well knows I love data, I love Excel. I have a whole school asthma dashboard, so that if I'm asked for information, I can give it at the drop of a hat. This many schools, that many this in my key, and I added it to our KPI, so it's now on our performance dashboard. So I'm almost sort of split it around, really. I'm now being monitored on the progress so that it keeps it on the agenda. And I think really it's just been a lot of hard work and determination and just constant narrative, pushing it through, sharing information and just keeping it on the agenda, like I said. Something I've also left off is evaluation. So we did evaluate year one. Sorry, I may have gone over my time, so I'll try and speed up, but we did evaluate year one by evaluating all of the training sessions and also evaluating the asthma leads experience of getting it set up in the schools that we could learn for year two, and I need to write that up. And then year two so far, so 800 trained in asthma awareness. That was actually when I wrote these slides. I'd say we're now 3 times that, which is brilliant considering we're only really about 12 working days into the academic year. We've already delivered 2 management of asthma and allergy training sessions. There was 1 taking place this morning, finished about 12:30. Met up with about 6 schools now to set it up for their year one. Some of our schools have moved into year 2. And all of our asthma champions have had their second year update on asthma care. So they're all refreshed and trained, ready for this academic year with support from ELF, which is always great. And that's how we really have pushed it through. So I guess it's a case of watching this space. I'm really excited to see where we'll get with year 2 and determined to get that 100%. Yeah, that's it. Thank you so much.
Heather, thank you. That was absolutely fantastic. And, real proactive work going on here. And I know from my own experience how very, very difficult this is, and actually what an awful lot of hard work it is. So well done. And also real schools really are that central point, aren't they? And they're really so important
Absolutely.
in this whole systems approach. So thank you, Heather. I hope you're going to stay around for questions at the end.
Okay.
Right, we're going to move on now. We've got Professor Errol Galliard, and he's going to talk to us about the management of asthma in children and young people from his own experience. Errol, over to you.
Good afternoon, everybody. Yes, I'm Errol Galliard, and I'm a respiratory paediatrician working at Leicester University Hospitals. And thank you very much for inviting me to contribute to this programme. And I will essentially talk about the asthma review. And my brief was to talk across primary and secondary care children's asthma review, but actually they're remarkably similar in brief, and therefore I haven't separated them out. Next slide, please. So I have no conflicts in relation to this presentation. Next slide, please. So this probably is my most important slide, and this is my 5 pillars of basic asthma care, and you'll find that they fit in very nicely with the just published CYP asthma bundle. So the 5 pillars, and I'm going to talk through all of these in slightly more detail, but the real important starting point is to get the diagnosis right, because that allows to communicate the diagnosis with the patient, and that gets them off to a really good start, taking their medication, understanding their disease going forward. And once they're diagnosed, then it's really important to monitor the disease, and this needs to happen with regular reviews or regular annual reviews in primary care, updating the personalised asthma action plan, checking control and checking inhaler technique. One area that is often slightly overlooked is to check on the patient's medication, especially their adherence to the preventer medication. And it's really important to detect SABA overuse early, because we know that this is an important risk factor for asthma deaths. I talked already about the importance of inhaler technique, and that's already also been highlighted by the pharmacist that came earlier. And we do need to detect high-risk patients who have poor control, who need regular courses of oral corticosteroids, and we know that are at higher risk of bad asthma outcomes. Next slide. So, why do we need to do this? I think it's really important to repeat this data over and over. So over 1 million children in the UK are treated for asthma, but importantly, and this is the latest set of WHO data that is available, we have by far the highest asthma mortality in Western Europe and one of the highest mortality rates in the world. And you can see that in some places, well, compared to some other places, it's up to 10 times higher. And there are reasons for this, and I'll be blunt, I think it boils down to money and capacity, and I'm happy to discuss that more later. Next slide. So, starting with my first pillar, asthma diagnosis. Why is this really important? Most children in the UK are diagnosed on clinical grounds, and the reality is, and this is not just a UK phenomenon, there is data from the rest of Europe, North America, Australia, many places to show that using this approach, doctors often get it wrong. And this is just some headline data: underdiagnosis 33%, overdiagnosis 20% is reasonably realistic snapshots. And what also needs to be borne in mind, there is huge variation from practice to practice, how many children make it onto the asthma registers. But as an average, this is probably broadly not far off the mark. So if we use more objective tests, then these rates of misdiagnosis could come down. Next slide, please. Really important to understand what this means for families when we get it wrong. Children get prescribed inappropriate medication, inhaled corticosteroids. These have unnecessary side effects. These inhalers are quite costly, and often this also means missing the real diagnosis for the child who has ongoing morbidity. And we also know that children who have asthma but are not diagnosed with asthma have a relatively poor quality of life, often miss school, and there is also the potential for a severe asthma attack. Next slide. Thank you. So, monitoring annual reviews. So this is what a good quality asthma review should look like, and it's actually not very different from primary to secondary care. It should include an assessment of asthma control, and I know in primary care mostly the RCP3Q are used. They are okay, although the asthma control test is probably better in children. Children need a personalized written asthma action plan issued ideally yearly, well, it should be done yearly, ideally at every review or when treatment are changed. And we know that about 2/3 of patients with asthma in the UK do not receive a basic level of asthma care, and that young people receive the worst level of basic care. And this is relatively recent Asthma UK data. Next slide. Thank you. So what I would really recommend to everybody who's not familiar with this document is the SIMPLES structured primary care approach to asthma reviews. And I know it says adults in here, but actually the work that Dermot did with a good group of people would be very highly applicable to children. Next slide. Thank you. So I'm not going to run through all of this, but there is a familiar theme that broadly reflects the 5 pillars. Smoking status is really very important for younger children. Exposure to cigarette smoke in the home really is one of the most strongly exacerbating factors for asthma attacks and poor asthma controls. And of course, young people may take up smoking themselves. And then it runs through inhaler technique, monitoring, and next slide, please. And then there is the pharmacotherapy, lifestyle, education, support. This in a table really summarizes extremely neatly how a thorough asthma review could be structured or should be structured. And this is especially applicable to patients who are poorly controlled. Next slide, please. So then there is a 48-hour, 2-day review after an asthma attack. This is one of the only 5 NICE asthma quality standards, and it's rarely performed in primary care. And the reason for this is that there is poor communication with acute care. There is no appointment slots available, and GPs often tell me that they're seeing loads of well children. However, the reality is that an asthma attack is a serious event, and also a time when parents, carers and patients are receptive to listen to their doctor to prevent further attacks. And therefore, this is really an important and underrated review, because at this point, it's a really good time to go through adherence, to go through asthma medication use, to reinforce good asthma management, and to discuss with the patient where they think things might go wrong. Next slide, please. So this is a template of an asthma action plan. This is freely available on the Asthma UK website. I just thought I'd show you an example because it very nicely lists what should be on there: usual asthma medication, what to do when things don't go so well, and also some advice when the child has an asthma attack and what should be done in this emergency situation. Next slide, please, which is part 2 of the asthma action plan. So it talks a little bit more about triggers, and some additional information available, some web links where patients and carers can get more information. And I think this is a really useful resource that, as I stress again, is freely available on the Asthma UK website. Next slide, please. So monitoring adherence and SABA use. This is really very, very important, has been stressed earlier as well, but is often not done as well as it should be. Good adherence, 70%. We can argue whether it should be 75 or 80%, but actually 70% is a pretty reasonable cutoff. And there is very good evidence to show that the average adherence to inhaled corticosteroids is roughly 35%. There is a good systematic review, and I'll show you some local data in a minute. Next slide, please. So this is some data that we gathered with 3 practices in Leicestershire, reasonably affluent practices, or practices situated in reasonably affluent areas, I'd like to say. And I'll walk you briefly through this. So the blue bars essentially represent a patient, and there is 49 patients on this graph. In the orange is the asthma control test, and on the right side, if you want, is the adherence in percentage. So if we're starting at the left, you can see that there is about 10 to 15% of patients in those 3 practices that take no inhaled corticosteroid medication at all, despite the fact that it's prescribed. And they have reasonably good control, bar 1 possibly. And that may suggest that this group has either not got asthma or it's very well controlled. And then we have this broad middle section where you can see this line going up and down. Lots of children reporting poor control, and 2/3 of the whole population has an adherence to inhaled corticosteroids of 50% or less. And then there is also an interesting group on the right, which again is about 10%. This is patients who pick up 100% of their medication prescriptions. Not clearly, can't be equated to them taking 100%, but they're picking up all their prescriptions. And some of these seem to have quite poor asthma control, and I would suggest that this is a group of children that is possibly undertreated. So just looking at adherence control really draws a really nice picture that would also lead on to further management. Next slide, please. So we know that SABA and overuse is not good at all, and this has been highlighted in the NRAD investigation, and is a particular problem in teenagers and young people. I could talk around this slide for a long time, because I think diagnosis, early diagnosis, education would probably prevent many times the overuse of SABA, but the current system and the way it is structured somehow leads children and teenagers very quickly to rely on their inhaled salbutamol rather than taking their inhaled medication. Next slide, please. So inhaler technique, really important to use licensed medication for children and not adult medication that people are often familiar with and then prescribe to children. And it's really important to use a spacer when prescribing MDIs. Spacer and face mask until about 4 or 5 years, and then a spacer just with the mouthpiece without the mask is more effective. And a dry powder can be useful from 8 years, and this should really be part of a good quality annual asthma review. Next slide, please. Again, leaflets, I think, can be quite helpful given to the patient to remind them at home beyond the yearly inhaler technique check. Next slide, please. And then importance to detect high-risk patients. And high-risk patients are those that have high SABA use, have previous asthma attacks, and have persistent poor adherence. And these can all be identified by interrogating practice databases. Next slide, please. So, problems in search of solutions. We need more objective tests to diagnose asthma. And many children who are prescribed asthma medication are not coded as asthma, and these have actually a higher rate of asthma attacks compared to children who are coded as asthma, and they don't benefit from the annual asthma review. Next slide, please. Last slide, I think. My second list of problems in search of solutions. Only approximately half the children are brought to their annual asthma review, so non-attendance is a really big problem and we need public awareness. And maybe this is where grassroots up, as mentioned earlier, would be helpful. We need to have better ways to flag SABA overuse. We need to have robust, high-quality annual asthma reviews, including adherence reviews, and we really need better asthma training and education for doctors and patients, and a better system to action post-asthma review, post-asthma attack reviews. Next slide. I
think that brings you to the end, Errol. Thank you so much.
Thank you.
Thank you so much. Your 5 pillars are fantastic, and that was a tall order in a short amount of time, and you achieved it brilliantly. Thank you. We're going to move on now to Tori. We are running a little bit over, but just to reassure everybody that the recording and the slides will be available on the HLP website. But I'm going to hand over to Tori now, because she's going to talk to us about group consultations in schools, and I think this is something that everybody's going to be really interested in. Tori.
Hi everyone. So my name is Tori. I'm the Community Children's Specialist, Wheeze and Asthma Nurse in Tower Hamlets. And like everybody else, we have multi-system approach across North East London, looking after children with wheeze and asthma. But our local group in Tower Hamlets is called Take a Breather. So today I'm going to talk about the group consultations that we did in school, aiming to improve outcomes for children and young people with wheeze and asthma. And this drawing was drawn by a 5-year-old child, explaining that asthma attack is being like having a bad monster. So our aim really was to stop the monster days and improve asthma care. Next slide, please. So we held different engagement events and asked children and young people and their families with asthma and wheeze how we could improve things. So we used their views and their voice to develop the group consultations and realised that families wanted us in schools. And also we developed the community specialist asthma clinic. And this is just some of the views that they gave us that are in the bubbles. Next slide, please. So we targeted 10 schools, a total of 287 children. Everyone that was on a blue inhaler came to the session, and the schools invited parents and children. And we did ask to have 2 asthma champions, so someone from school that would come to help support. We did a pre-questionnaire with the children and the parents, and if the teachers attended, just so that we could get prior knowledge. We also then did a training session, and that was based around asthma, wheeze, allergies, looking at the condition, what causes it, looking at medicine management, symptom control, how to use a personal asthma plan, what to do in emergency, when they should be seeking help and advice, so looking at poor symptom control. We also, if you can see the blue clouds on the presentation, we asked the children what they were worried about, and most of them were worried about stopping breathing and actually coming to hospital, so it was a concern to them. So we had a group discussion as well at the end of the presentation, where they were able to share their knowledge, experience, if they had any worries or any questions. And this gave an opportunity for peer support and some more individualised conversation around their wheeze and asthma. We also did an asthma control test to identify if they had poor symptom control. And then we did a post questionnaire to ask them what they had gained from the session and to check that their knowledge had improved from the session. We did also have health advocates in some of the sessions if we felt that there was going to be a language barrier, which did sometimes make the session a little bit longer. Everyone who attended the session did receive a personalised asthma plan. They received an information leaflet so that they could take that back to their parents who couldn't attend to share that information. And they were also all given a certificate just to say that they were part of that session. Next slide, please. So children and young people with asthma and wheeze are not attending hospital. They're not going to the GP despite having poor symptom control. So we've got quite a large population of children and their families are not understanding what poor symptoms are and when they should be going to seek help. And I think a lot of our children will cough at night time, will have not do exercise and think that this is normal, and it's trying to make sure that they understand that that's not normal when they should be seeking help. So the group consultations also helped us to understand that they need to have support when to seek medical review, because 38% of the children that were reviewed on their ACTs had poor symptoms and needed to be referred on to the specialist asthma clinic. And we also identified that children didn't have asthma plans, and they didn't have age appropriate spaces. Now, one of the issues around this is that often GPs or secondary care may do the asthma plans, ask the parents to take it to school, and it's not actually getting to school. And also we had a lot of children in schools being prescribed spaces for under 5-year-olds when they were over 5. Next slide, please. So at the end of the group consultation, we found that children, young people and families had an increased understanding and confidence in managing their asthma worries, and that the session they would highly recommend to their colleagues or other family members or children. Next slide, please. So unfortunately, only 43 out of the 76 children that had poor ACTs was reviewed in difficult asthma clinic. One of the reasons for this is that we had some children that DNA'd, school weren't communicating the child's details for me to be able to find them on the system. And also I've been sort of doing the group consultations on my own as well as having a clinic and patient list to run. They all received a 30-minute consultation looking at their history, diagnosis, medication review, prescription uptake, looking at a respiratory examination and peak flow, giving them education on asthma and wheeze and how the medication works, and demonstrating how to use inhalers and EpiPens and nasal sprays, and what to do if their symptoms get worse, using personalised asthma plan, looking at triggers, and also covering things like allergic rhinitis, allergy and eczema. When they were reviewed in clinic, over half of the children had improved symptoms following the group consultations, and this showed that they had an improved understanding on what asthma is and how to manage their medication, and most of them had started complying with taking their inhaled corticosteroids. Those who had poor ACTs on subsequent appointments had improved symptom control, but there was a small proportion which needed ongoing management, and this mainly was because of compliance or needing to increase treatment and consideration for referral to secondary care. Next slide. So following our group consultations, we obviously had found lots of information, and these are just some of the things that we've been trying to develop and take forward. So we've developed asthma friendly school guidelines and a toolkit with all of the information to make it easier for schools of how to access and what pathways they need to follow to make sure that children are safe in schools. And we've been doing a lot of work with the school nurses and with schools to try and make the schools asthma friendly. Not quite as developed as Newham, and still working hard to try and get this a bit more embedded within Tower Hamlets. We have developed a standard asthma plan, which you can see on the presentation, and that is mostly because children weren't getting the individual plans. We wanted them to have a standard plan so school knows what to do in an emergency if the child's having an asthma attack. So we're just rolling out trying to get those all printed for all of the children in schools. And one of the things on this is parents can sign that they're happy for their child to use emergency salbutamol, and this plan will actually stay with the child. It doesn't need to be redone again, obviously, unless there's something happens to the paper that it's on, but it's one thing for the school to do, and they don't need to redo that again to try and cut down on their workload. We also have been delivering lots of training across all sectors to try and improve knowledge and confidence around asthma and diagnosis. And following group consultations, we've acknowledged that children and young people are not seeking review for poor symptoms control, and we're working with partners to provide ongoing group consultations in primary and secondary school on a yearly basis. So it's something that we're developing to try and take that forward. And I think that's it, all I've got to say, really. I think that's the last thing.
That is brilliant. Thank you, Tori. Again, fantastic work. You know, I'm absolutely bowled over by some of the work that I'm hearing about in this session today, and, you know, well done, everybody. And because it's all been so interesting and there's been so many questions, we have, of course, run out of time. So for anybody that does need to leave us, please be assured that any questions that haven't been answered so far, we will be sending through written answers to them for you. And as I said earlier, the slides and the recording are going to be available on the HLP website. But can I just come to our panel now? So thank you all very much. I really appreciate all of your presentations and your engagement so far. You know, there's lots of questions. I'm going to mention them. So Oliver, there's one for you about the peer review process that maybe you can touch on in the chat for us. And there's also one, and I think one that I'd just like to talk about really is the one about adolescents with poor adherence to steroid-based treatment. And does anyone have any suggestions or experience on how to address this, given the many underlying reasons? And I think between you all, you've touched on this particular one, so it's an interesting question. So actually, Errol, can I come to you, please, about adolescents with poor adherence? Have you got, in 20 seconds, any top tips for our audience?
I think talk honestly to the teenagers, explain to them what the risks are, explain to them why they shouldn't be on a SABA inhaler and overuse it, and explain what the steroid inhalers does for them and how it improves their asthma control. I think they need to be, because teenagers sometimes fall into you still talk to the parent, and that doesn't really work. I think they need to be talked to directly, they need to be fully involved in the process, and that helps in many cases.
Yeah, brilliant. And I can see lots of other panel members nodding their heads there. Darush, any tips from you with teenagers? Very briefly, please.
I know, very brief. Yeah, straight away, ideas, concerns, expectations, shared decisions, without a doubt. But there's something called the reliever reliance test, which I've seen, which is, I think, very good. It gets, because asthma management has changed over the years, and I think there's still confusion around you know, what's the important inhaler. So that's a really good self-test that people can do, and they can digest that information. I think teenagers don't like to be told what to do. No, do any patients really like to be told to do what to do. So I think that's really useful. And it's also got some evidence base behind that. Professor Rob Horn was behind that. Yes. And then the other thing I would suggest is just the wording we use, the communication skills around some people feel, again, thanks to Professor Rob Horn on this, how asthma is a condition where our lungs react too strongly to certain triggers. Some people think their lungs are weak, but they're actually reacting too strongly to triggers, and how, and how we naturally release.
Oh, we lost you then, Darush. We lost you then, but that work you mentioned, actually, I think somebody's put a link to a podcast about working with young people in the chat. So thank you so much for that. And I've just got one final question before we close, actually, and Heather maybe, and Tori and Oliver, there's questions around working with housing and housing associations. Just wonder if, very briefly, Heather, starting with you, you've got any experience of that?
I don't have any direct experience, but we did have someone come and speak to us, Tori. Do you remember at the last North East London asthma meeting for asthma nurses? And that was really useful. And I've disseminated that information across our service so that we're able to obviously use the advice that they provided if we do have anything, you know, any cases where that is an implication. But no, I don't have any direct experience, I'm afraid.
I think with housing, it is very difficult, and especially in our area, we have lots of mould, and it is difficult with different housing associations. So there is a tenancy agency that do help support families, and they look at it more from like a legal point of view and give them advice. So I can put their web link in the chat for people to look at, but that's what I'm using at the moment, because that seems to be an easier way to get forward. They will listen if you put in some quotes about law and things like that. So I'll put that in. I think that's helpful.
Thank you. That link would be enormously helpful. And Oliver, final word to you then on housing really, and your experience as a GP, and to share.
Yeah, I think I mean it is a challenge, and I think it does depend on you know, where you are in the country. Housing stock is not great. Certainly in where I practice in Camden, there are issues with that. You know, demand is outstripping supply, and also just resource to spend on it is quite light. So I think the sort of moves towards thinking about the role of home visit for complex asthma, and including that as part of assessment, because I think it's you know, we can think about things like damp as being, you know, this kind of major problem, but actually, you know, clutter, internal environment, internal air pollution, all of those things are more easily fixable.
Yes.
So I think it's important to consider the role of those things, rather than the things which might be a little bit more intractable and take longer to address.
Yeah. That's absolutely brilliant, and I think a really good note to finish on, actually, because, you know, you've highlighted the role of the home visit there as well, which I think, you know, when we're talking about a whole systems approach to paediatric asthma, is really important. You've been a fantastic panel. We have overgone time, and I'm sure you're all desperate for your lunch at this point. So I just want to say thank you so much to all of you. Thank you so much to the NHS England Children and Young People's Asthma Transformation team, who, as Ian said, are doing absolutely fantastic work to bring all of this to fruition. And we look forward to the publication of the asthma transformation bundle tomorrow. So watch this space. Thank you, everybody.